Thank you, Dr. Sharma, Dr. Kinney, Dr. Narula, for inviting me to the top 10 topics in cardiology and for including antithrombotic therapy update in there. It's really a pleasure. Important for you to note my disclosures both to the institution and to myself and my spouse. Today, I'll talk about two topics as requested by our course directors: DAPT versus single antiplatelet therapy after PCI, and then triple versus dual therapy after PCI in patients with atrial fibrillation. So antiplatelet therapies are needed both in primary and secondary prevention and have been incredibly useful in preventing ischemic events tremendously, even in subclinical atherosclerosis, but very importantly in secondary prevention, especially after PCI. And we've seen this play over and over again, especially in terms of stenting, where dual antiplatelet therapy now have become the cornerstone of treatment of patients who receive stents, whether it's drug-eluting stents or bare metal stents. And a lot of it has to do with the stent scaffolds and the important nidus for thrombus formation, et cetera, especially early on, right after stenting. And if we all remember back in 2006 with the first generation DES, where we saw stent thrombosis as an important event that was happening in patients with first generation drug-eluting stents, and the firestorm that came from that in 2006, where there was increased deaths in patients receiving drug-eluting stents, and which called for longer-term dual antiplatelet therapy durations, and the panel that then gave a 12-month duration of dual antiplatelet therapies for all DES at that time, which was all first-generation DES. And we all know that drug-eluting stents have had some of the bitter and sweet, no restenosis, fantastic. In that first generation, there was a important delayed healing, inflammation, incomplete apposition, and so a lot of issues in that first generation DES. But let me tell you that a lot has changed since that first generation DES. We now have advanced stent technology with thinner struts, different kinds of biodegradable or even fluoropolymers that are thromboresistant, intravascular imaging to enhance and improve the best possible results that we could get in the most complex lesions, the potent antiplatelet regimens that we now have at our armamentarium, prasugrel and ticagrelor, and then, of course, very, very important, excellent, improved secondary prevention strategies with statins and PCSK9 inhibitors, and, of course, other therapies that we give our patients to prolong their life. No question that the early versus current generation DES have made a tremendous impact in this current generation DES with reducing death and MI, and a very, very important, wonderful result with the current generation DES, such that in 2017, the European Society of Cardiology, irrespective of the intended dual antiplatelet therapy duration, made DES the preferred treatment option with a class 1A recommendation. But the duration of dual antiplatelet therapy, especially in those patients with high bleeding risk, is very much unknown. 1 month, 3 months, 6 months, how long? And shorter is probably better in most patients because bleeding matters. And the important comparative impact of bleeding versus myocardial infarction on mortality is something for us to that has paid a lot of attention in the recent years, in the last decade, really changing our focus from stent thrombosis now into not putting patients at a very high risk for bleeding, to bleeding avoidance strategies to help mitigate that risk. And of course, understanding that myocardial infarction and severe or major bleeding are both important and attribute to deaths. And in fact, there are some kinds of bleeding that are much, much worse than myocardial infarction, spontaneous myocardial infarction, which is a very, very important predictor of mortality. And here's some work from Marco Balgamigli showing that BARC3C and greater, those are really, really, really important bleeds to be avoided. And that trade-off is incredibly important, such that you're seeing a similar BARC3 and MI, both are very, very similarly important. But when you get to BARC3C and above, it becomes even much, much more important. Because when the patient bleeds, there are important consequences. We stop their dual antiplatelet therapies, and then there is this rebound platelet activation. And with an incomplete stent apposition or endothelialization, you can end up with stent thrombosis or MI, the very thing you're trying to avoid. And in bleeding, where there is transfusion and there could be inflammatory biomarkers that give a really important predictor of mortality, and then just that whole extravasation of blood, dropping the hemoglobin, and these all could lead to the very kinds of things that we're trying to avoid. So it becomes very, very important for us to balance the ischemic and bleeding risk. And the more potent means more efficacy. But is that correct? Should we always be thinking in that direction? Or what about when we're stacking therapies on each other? What harm are we enduring? Well, it made us kind of sit back and think about the role of aspirin. There are real important uncertainties around the use of aspirin for secondary prevention. Three major arguments challenge the use of aspirin for secondary prevention in combination therapy with other antithrombotic regimens. And a lot of it has to do with the bleeding risk, the current novel antithrombotics that could really are potent enough that really make aspirin a non-player. And then very important other risk reduction therapies that may question the need of aspirin. And then, of course, very important issue about the P2Y12 inhibitors as the alternative therapy that may very well have an important signaling effect on thrombotic and inflammatory process. And there is wonderful clinical efficacy of P2Y12 inhibitors to reduce stent thrombosis. So this understanding of kind of thinking about maybe dropping aspirin, especially when you have a potent P2Y12 inhibitor, is not a new concept, even though everyone thinks of it as an innovative concept. It really has been around a while. Here's work that has been shown. This is a really interesting work that tells you that aspirin might actually abolish or decrease the antithrombotic effect of P2Y12 receptor blockers in vivo. That's mediated by the amplification of antiplatelet effect of inhibitory prostaglandins like PGI2. And in the presence of P2Y12 inhibitors, aspirin provides very little or no benefit at all. And this has been well documented with both prasugrel and ticagrelor before we even did any of these big studies. But nevertheless, our Japanese investigators with the STOP2 trial with a single stent platform, this was all Zion stent patients with 1 month DAPT versus 12 months of DAPT. And in the 1 month dual antiplatelet therapy, instead of dropping the P2Y12, they actually dropped the aspirin after 1 month and continued with clopidogrel monotherapy compared to aspirin plus clopidogrel, and looked at the 1 year outcome. And what was really interesting is that the net adverse clinical events were in favor of a monotherapy of P2Y12 monotherapy after 1 month of DAPT, driven mostly by reduction of bleeding, no difference in the ischemic endpoint, and a very, very interesting and important outcome in this 3,000 patient study. The Smart Choice investigators used 3 different stent platforms, and here they went between 3 to 12 months of DAPT, once again going to a single P2Y12 inhibitor, and they showed very, very nicely death MI stroke at 12 months in this 3,000 patient study to be very, very similar and non-inferior. And in fact, the bleeding was significantly lower with a shorter duration of DAPT. So here it is with just clopidogrel monotherapy. And I'd be a little bit nervous because clopidogrel non-responsiveness is prevalent in certain patient populations. And I would like to test patients, but still, despite that, here they were able to achieve this great results here in Korea and in Japan. But the global leaders investigators did the largest ever all-comer study, 16,000 patients who were randomized to an experimental arm of aspirin plus ticagrelor for 1 month, and then ticagrelor monotherapy for the next 23 months versus the control arm, which basically took the convention of what we were doing with our ACS patients with aspirin ticagrelor for a year and then aspirin monotherapy versus the stable patients getting aspirin and clopidogrel for a year and then going to aspirin monotherapy. They looked at the composite of all-cause mortality and Q-wave MI up to 2 years with a hypothesis that the experimental arm would be superior. I think a very lofty goal. And looking at the investigator-reported non-adjudicated BARC 3 and 5 bleeding up to 2 years. They missed that superiority endpoint just narrowly, and unfortunate that this was a missed opportunity because in my mind, non-inferiority in the QMI and mortality is a win when you're dropping aspirin and going to a very simple ticagrelor monotherapy. But there was important issues here. The lack of centralized adjudication, investigator reports led to underreporting of a lot of these events. And the comparator arm, that reference group, having these multiple comparisons between ACS and stable patients made this study very difficult to interpret. But nonetheless, it gives you an opportunity to go after ticagrelor monotherapy. And we did this in the Twilight trial. At around the same time, we had designed the Twilight study. Here, we asked for high-risk patients who were at high risk for both ischemic and bleeding complications, and in whom the investigator or the clinician wanted to send that patient home on aspirin and ticagrelor using some of the, not just their choice, but also some bleeding and ischemic risk factor features that were included in the trial. These patients were given 3 months of aspirin and ticagrelor in an open label fashion. And at 3 months, they were randomized to aspirin plus ticagrelor, continuing that for another year, versus ticagrelor plus placebo. And then they were evaluated at 15 months after the PCI or 12 months after the randomization for ischemic and bleeding endpoints. And what we found was an incredible reduction in BARC 2, 3, and 5 bleeding, with the numbers needed to treat of only 33 to reach this, and absolutely no difference in death, MI, and stroke. So this study showed a non-inferiority of death, MI, and stroke in over 7,900 patients, and with a fantastic ability to go with less bleeding and no increase in ischemic events out to 1 year with ticagrelor monotherapy. Then we had our investigators, the Taiko trial, doing a very, very interesting work in ACS patient population. And here they randomized patients with acute coronary syndromes to ticagrelor, 3 months of ticagrelor, 3 months of DAPT followed by ticagrelor monotherapy versus 12 months of DAPT with ticagrelor plus aspirin. And here, what they found was a major reduction in bleeding and, of course, no difference in their ischemic output. So the overall net adverse clinical events was in favor of this ticagrelor monotherapy. And you can see the curves separating exactly at 90 days, driven by reducing the bleeding complications. The story is not complete without also placing prasugrel monotherapy as an important study. The ACID pilot trial is ongoing, and I think it's also going to give us another option with prasugrel. And the results are really, really interesting and showing that they were able to achieve good results. But again, this is a very, very smaller study, and we're really looking for larger trials. They did not see any stent thrombosis in this study, and it's very, very interesting. But at the end of the day, it's all about the balance. Individualized approach is the way to go. And what we need to do as clinicians is to give the right therapy to the right patient by evaluating their risk of bleeding and ischemic complications. When they are equal, we still need more data. We are really, really, here's where the equipoise, when both you have low ischemic risk and low bleeding risk. And then here, when you have high ischemic and high bleeding risk, in both of these areas where there's overlap is when we need to use a tailored approach and really kind of thinking about ticagrelor monotherapy and these newer innovative approaches of de-escalation, et cetera, after the period of risk. But when you have a low bleeding risk, you should not shorten your duration of DAPT and actually increase it. And when you have a high bleeding risk, you can shorten that duration. So again, a very individualized approach is how we need to approach this. What about the biggest dilemma? A patient with atrial fibrillation. These patients that are at risk for the most devastating complication of stroke. Oral anticoagulation is seminal in treating these patients. And we do know that they also have an overlap of when they are when they have coronary disease and require stenting, dual antiplatelet therapies are needed. So what you end up having, about 5 to 10% of these patients undergoing PCI having atrial fibrillation, and for us having a very, very important issue of the hazard ratio of mortality by just having new onset AFib after PCI. These patients are at high risk. And how do we deal with this? Take a look at the number of patients of atrial fibrillation, 20 million of atrial fibrillation. Oral anticoagulation is indicated in about 16 million, for about 5 million with coronary disease, and 1 to 2 million requiring a revascularization. And the prevalence of atrial fibrillation will continue to grow. But what we need to do is to find ways to not to stack therapies on these patients. The synergy of oral anticoagulation and antiplatelet therapy are incredibly important for us to think about this dual pathway and finding ways to come up with a possibility of a treatment effect that would keep these patients free of the bleeding complications that is so prevalent in this patient population. And if we look at the novel oral anticoagulants, it's a place to be for these patients for treating atrial fibrillation. Certainly, novel oral anticoagulants are protecting patients against the most devastating issue, which is hemorrhagic stroke. And of course, all-cause mortality is in favor of novel oral anticoagulants. So whenever possible, we should, if we have a patient who's still on Coumadin or VKA antagonist, we should really bring these patients and change them to a novel oral anticoagulant. And before we had WUST, and I'll discuss the WUST program, triple therapy was the standard of care. And look at the bleeding hazard of these patients, almost 4 times as likely to have a major bleeding episode. So we need to think about how to de-escalate therapies in these patients. And it was the WUST investigators in the Netherlands who did this by randomizing 573 AF patients undergoing PCI, where they just took out the patients and stopped the aspirin at the time of discharge, went to a dual therapy versus the standard of care. What they found incredibly is that these patients were obviously Even mechanical valves were included. Most of them were atrial fibrillation. But very important results of this trial, which was published in the Lancet now almost 7 years ago, was that going to a non-aspirin treatment, dropping aspirin, reduced bleeding by 64%. And in fact, it reduced ischemic events. There was no signal of harm, and mortality was in favor of a dual therapy. Now, these endpoints are underpowered. We can't say you're benefiting ischemic events. You're certainly reducing bleeding without the ischemic harm. And the Europeans, their perspective in 2017 for the DAPT update, in patients with oral anticoagulants and PCI, there was no default strategy, and you had to consider bleeding versus ischemic risk. When you had the chance, in high bleeding risk patients, when you had that, you could go to a dual therapy and drop aspirin, but the duration of aspirin on the triple therapy, no matter where you are, is no more than a month. So really a shortened duration of aspirin therapy in these patients and dropping it. And this algorithm is also very similar to what we're doing in the North American consensus back in 2016, and where they are really coming up with a default strategy of about up to a month, and really going to this dual therapy for the majority of the patients, but those who are at high ischemic and thrombotic risk and low bleeding, giving up to about a month. And then for those at low ischemic but high thrombotic, low ischemic but high bleeding risk, going to a triple therapy for at least a month, or even sometimes 6 months in those patients. So it was really there for 2018, and we're now coming up with the 2020 updates for this consensus document. And we have so much more data now. First of all, we had Pioneer, we had Redual, we had WUST. All of these showed that dropping aspirin is the way to go. The Augustus trial was the trial that really took under consideration the evaluation of dropping the aspirin in a blinded, largest study ever. And they had two independent hypotheses of showing non-inferiority of apixaban to VKA for bleeding evaluation, and that the triple therapy is inferior to dual therapy in terms of these important bleeding endpoints. And 4,600 patients in a 2x2 factorial design with placebo embedded in here for aspirin versus placebo in a double-blind fashion, and showing such an important effect of dropping aspirin. When you drop aspirin, in whether you're on apixaban or in the VKA arm, you had a major drop in your bleeding complications. And the best possible scenario was if you gave the patient apixaban plus a P2Y12 inhibitor and no aspirin, the placebo arm, the lowest bleeding. And in fact, in terms of death and hospitalization, there was no real difference. You reduced bleeding tremendously when we dropped aspirin. And so since then, I mean, you can imagine the updated meta-analysis that has now come out. There have been two of them that have been published now. This one that I'm going to share with you is in the largest numbers, and you can take a look and see what's going on here. That the major adverse cardiovascular events are very similar, whether you go to a dual therapy or a single antiplatelet therapy in combination with a novel or a VKA. Very important. But bleeding is where you're gaining the best possible benefit when you drop aspirin. And no matter which way you look at it, in these patients, the sooner you drop the aspirin, the faster you will gain the results in reducing the bleeding complications. And in overview, this includes intracranial hemorrhage. And if you look on the thing you worry about the most is stent thrombosis. So we need to really still evaluate the risk of stent thrombosis. And if you look at the stent thrombosis numbers and put them all together, there was a little bit of a signal of harm, but it crosses the line of unity, and we're going to have to look at this on a case-by-case basis. So to conclude here, in patients with AF undergoing PCI, there are no significant differences in novel oral anticoagulant plus a single antiplatelet therapy, usually without aspirin, and VKA plus DAPT strategy in terms of major adverse cardiovascular events. But let me make sure you understand that it will reduce bleeding tremendously, and it will be an extremely helpful situation. The story of stent thrombosis will need a IPD, individual patient data analysis, that's going to take place here at Mount Sinai at the Icahn School of Medicine with all of our collaborators from all of these clinical trials. So I want to thank you for your attention, and thank you again for including me on this, in this very, very fantastic symposium on the top 10 list in cardiology. Thank you for this.